Thank you so much, Selena, and thank you so much, Rubin and Mort, for inviting me here. This is one of the best meetings where there is a great emphasis on practical applicability, but also mixing with science and how we take it from really bench to the bedside. And so my title is quite provocative. It's how many myelomas are there? And so more important question is, why do we want to know that? And the primary purpose might be, and Dr. Morgan has helped me put all the data that we would go into discussing more philosophically, what about myeloma. And so we want to see if we can find how many myelomas are there. We can treat them differently, each patient differently or each group differently. Also, depending upon the types of myeloma, they may have different survival. We can give different prognosis, and I think that's an important aspect to find out. And then we can make long-term plan, and we can also do research to then target each of these diseases specifically. So if you go to one of the data earlier on, where we were looking simply at how many chromosomal changes are there and what type, there were just two subtypes. One subtype is what called hyperdiploid myeloma, where there is increase in certain number of chromosome. All the reds are increase in the chromosome. So you can see chromosome 3, 5, 7, etc. are increased. And the second group is non-hyperdiploid myeloma. Two types. This was recognized many, many years ago. And even today, this is quite appropriate. And the reason this is appropriate is because if you look at their survival, the hyperdiploid myeloma lives longer. The non-hyperdiploid myeloma has lesser survival. And so these two things, so in old days, life was simple. Two groups, we do cytogenetics, find it is HMM or non-HMM. One is going to live better, the other one is not. Didn't have any specific treatment, but things worked. I don't think we are used to simple. We need to make it complicated. So now started looking. And in the same figure, then you can look at other subgroups. There's a group of myeloma, for example, there's chromosome 13 deletion. There is another group of myeloma where you look at the top, the red bars are 1q amplification. So we're beginning to have subgroups within these broader categories. And then there is this 17p deletion. So another group comes up. So then putting together the non-hyperdiploid and hyperdiploid myeloma, now we are dividing them into multiple subgroups. Hyperdiploid has trisomies, but not every patient has all the trisomies, so we can divide either having more trisomy 11, trisomy 5, trisomy 3s, and their differences. And then on the non-hyperdiploid side, we have found out that there are mutations, translocations involving chromosome 14, the IGH region, also a little bit kappa and lambda, and then we can subdivide them into multiple subgroups. There may be FGFR group or MEF and other groups. So now we have begun to divide them into further differentiated myelomas. So the number of myelomas are now increasing from 2 to a greater number. And then, of course, deletion 17p actually straddles between the two. 1/3 of the patient on the hyperdiploid side could have it, and other side too. And so utilizing that information with also then available 10 years ago or so, expression profile data, the myeloma groups were then divided into 7 groups with specific gene expression, cyclin D1, MEF, FGFR, or other. So now we are expanding the myeloma groups to greater numbers, so there are more myelomas. And if we look at each of these 7 groups, they are characterized by unique expression patterns. So one group in the top in the red is 414 translocation expressing FGFR. Maybe we can target them separately. A second group expresses MEF. Another group is chromosome 6p change with expression of cyclin D3. And then there is a group that is chromosome 11 with extremely high level of cyclin D1, as you can see in the green in the middle. And then there is a whole group that expresses different level of cyclin 1, cyclin D1, 2, and 3. And then you can summarize in the bottom, some are hyperdiploid, some are not. So it's becoming complex, but also has some theme to it, some targets that are associated with this group. And so with all this complexity, and this particular slide that I showed previously, it is not a new slide. It's been around for like 10 years, but I don't think any one of us in this room have used this clinically because we still like simple. When I see a patient in the clinic, I don't want 7 or 10 groups and CD1, CD2, PR, and other group. We want simple. So what is the simple thing? This is what we still use. There are two types of myeloma, a high-risk myeloma and a standard risk myeloma. Defined by cytogenetics, and those are well defined just for simple purpose, 17p deletion, 414 translocation, 1416, 1420 translocation, so 14q related changes. It could constitute one group. If you've done cytogenetics, that's bad if it is positive. And then gene expression profile, if it's a high risk, as I will show in a second, that's also a group that's considered high risk. And maybe today, in reality, in clinic, we would treat them a little bit differently, as we will see in a minute. And then the rest are standard risk groups. So we want to make it simple, not have 7 groups, but 2 groups. Again, by nature, we want to make it complicated because we want to go into the details of what the biology is. And so, utilizing gene expression profile, there are various signatures that are available, as we just saw previously. 70 gene signature is most widely advertised and utilized. There's a 92 gene signature, maybe a little bit stronger than this. Each of them identifies subgroup of myeloma, high risk, intermediate risk, and good risk with different survival. And maybe we can utilize this instead of 2 high and intermediate group, high and standard group, we can use it as 3 group. And that's one of the things that we are looking. The problem in utilizing such gene expression related differentiation of types of myeloma is that we're only looking at one aspect in the myeloma genome. And there are many other things happening in the human genome, in the myeloma genome. There are DNA changes with mutations, copy number alterations. Of course, RNA transcript is important, but then there are RNA splicing, microRNA, link RNA, and other changes. And so when a myeloma cell behaves in a certain way, it's not just because of one, it's because of the composite effect of all these various changes. So we do need to look for greater details to see are we missing certain type of myeloma that we should be focusing separately and distinctly. And that's where some of the sequencing results that came into picture in last 5 to 7 years. It's been relatively new. So one of the things that came out of one of our study was that in a given myeloma cell, there are around 58 mutations on an average. So even in one patient, one myeloma, there are many, many mutations. So it's complex, although it may be individual. And because of so many mutations, maybe each myeloma is different to some extent. Some of these mutations, as you can see in the big blue circle, are mutation in one patient each. So maybe not so critically important, affects just one patient. The one in red, which are also quite a few of them, there are more than one patient. Now, when we look at, do these mutations go with any certain pattern of cytogenetics? It doesn't. And that tells us that there are many different types of colors of myeloma here, which is very different than Waldenstrom microglobulinemia, where almost every patient, 90 to 93% of the patient, has mid-88 mutation. So maybe there is only one Waldenstrom, but that's not true, entirely true for myeloma. And that's why treatment for myeloma has been what it is, which we will see in a minute. So what are the mutations? These are the list of commonly mutated genes, RAS, RAF, P53, FAM46, etc. And theoretically, each of these mutations can create a distinct myeloma. So we may not have every myeloma patient separate, but all those with KRAS mutation may have one disease with some similarity that can be targeted in a specific way. It's not so, it's more complex than that in reality, because even in a given patient, there are more than one myeloma present, and as I will show you. So there are many myelomas, but if you take one patient may carry more than one myeloma. And the reason is this, that if you look at a patient's myeloma, for example, on the left side, I can point it here well, the red and the blue and the green dot circles suggest mutations in RAS, KRAS, NRAS, and BRAF. Even though these 3 genes are sort of connected in the same pathway, MEK-ERK pathway, a given patient may have 2 mutations in the same pathway. One patient may have only 1, and some may have more than 2, suggesting that within the patient, There may be some cell with one mutation, some cell with another mutation. And then we need to target both separately, maybe both behave distinctly. And the right side figure shows that there is a variability. Some cells with mutations are 80%, the others are 20%, and the mixture of it. So there is a real clonal diversity within the patient with different driver mutation. And now we have begun to understand how does this happen, that within a patient, how can a clone evolve into becoming a different or more myeloma? And there, on the right side, I won't go into the biological details of it, but there are various mechanisms that will lead to progression of clonal evolution. And these pathways may be more something we should be after, because the pathways which causes myeloma to change, then become drug resistant and eventually patient dies, are the pathways that drives the disease, and maybe those are the type of myeloma at the root cause are the basic families or the groups of myeloma we should go after. There are now, these are 2 here in this publication we had a couple years ago, but there are now 6 to 7 of these signatures which may be driving myeloma, and we may end up with drugs after them. And there is a prognostic significance. If there are many mutations in myeloma, those patients don't do so well. If there are less mutations in myeloma, they do relatively better. So again, we are beginning to differentiate the family. Now, with whole genome sequencing, what I showed was whole exome sequencing. We have 58 mutations per patient. Whole genome sequencing is much more deeper. It's almost 100-fold deeper. And so we see almost 5,000 mutations per patient. And doing that kind of analysis, now we are identifying much more complex landscape. And you can see that there are so many mutations affecting all different areas, from cyclin D1, immunoglobulin heavy chain, lambda light chain, kappa light chain, MYC, etc. And each bar has its own value. So you can see that within the genome, 23 chromosomes, pairs, we see significant various mutations that may be driving the disease. And so how many? We have almost 500 events per myeloma sample. And it's not only in myeloma. As you can see, in smoldering myeloma, the blue bar is not very different than myeloma. So even when we don't treat the patient and call it smoldering, there are enough mutations that are causing the change. And all these mutations and translocations that are identified are not all IGH or kappa lambda chain. 75% are others, which we have not even described very well yet, except for this beginning of description using this kind of technologies. So I think we are unraveling more and more complex family of this disease. And so why do myeloma family grows within the given patient? For many reasons. One is inherent genomic changes. They are programmed to change because they need to survive the treatment we give. But then there are epigenomic drivers which are beginning to understand, microenvironmental influences from stromal cells to immune cells and others. And then, of course, pressures of therapy. When you give therapy, one cell goes away, but 2 more comes up because they survive what we do. So complexity of this interplay leads to development of more myelomas within a given patient. So how can we study this? We need a simpler method. So one of the things we have developed and beginning to utilize is this simpler targeted sequencing platform. Instead of showing 50,000 or 5,000 mutations that in our practice we cannot utilize, a simpler approach like this may be more helpful, where we have only looking at 246 genes and certain areas to look for copy number and translocation. So to give an example, using this kind of sequencing approach, we have evaluated 500 patients. And now using this approach, we can identify the chromosomal copy number changes, 1q gain, 13 deletion, 17p deletion, which is on the top left panel. We can look at certain genes copy number increase like MYC. And on the right side, using the same one platform, we can now look at translocation involving chromosome 14, kappa and lambda chain. So instead of our needing to do FISH and cytogenetics and sequencing, with very few myeloma cells, we can now identify most of them quite easily using one test. So this is something that would become available and applied in a near future. And the bottom line would be that using such a process, now we are beginning to identify more recurrent genes, evolution of genes, gene mutations in a given patient over time, and we can utilize in a practical term. So the question is, if we have so many other families in myeloma, there are many myelomas, do we treat them differently? So if you go to the simple algorithm, which is where we have two types of myeloma, high-risk myeloma and a standard risk myeloma, which is what we apply today in the practice. The definition of high risk can change a little bit, but we still have at least some consensus for today. There are a few things we look differently, and I think you are going to have greater discussion on this topic later in the day in the myeloma session. But the point is that when high risk, we do something more. The idea is not that we should do something less in standard risk. We are still not curing many patients yet. We may be curing some, but not many. So we still need to be aggressive for standard risk. But in high risk, we use novel agent with 3-drug combination, as we do for standard risk, but then we add something more. There is a new data coming out. Maybe second transplant may have some role in high-risk disease. Allogeneic transplant is an important areas where high-risk patients should be considered. CAR T-cell therapy, another area where we should look at. And then we need to have multi-drug consolidation, multi-drug maintenance. Usually we give lenalidomide for maintenance for standard risk. Maybe we should give proteasome inhibitor also with it, and there is some data to show it. So there are ways of treating high risk today. What's more important is that now that we identified other myelomas, can we go after them specifically? So can we go after KRAS myeloma, BRAF myeloma, or P53 or FEM46 myeloma? And there's a very good one-case publication that exemplifies how we can go after each of these myeloma individually. So one of the patients with BRAF mutation in myeloma, classic V600E, those of you who also treat melanoma know this mutation very well. There are multiple drugs available for that particular mutation, and this particular patient got vemurafenib, which is going after the RAF mutation. And patient quickly responded and had all appropriate changes in biology, so very good response. What happened in this patient over time is very important. So we can use a RAF-directed therapy to treat this patient with RAF mutation, even in myeloma. However, patient after 10 months, having initially responded, there were 5 lesions, all disappeared. Good response, PLAT-CT became well. After the initial treatment, 10 months later, patient relapsed. 3 of those 5 lesions increased in size. They were sequenced. And what was found was that those areas had a new mutation in RAF, which was downstream of RAF. So that's why the RAF inhibitor was not working. Interestingly, the 3 areas had 3 different RAS mutations. So patient already had 3 new myelomas coming up, which was not responding to the drug. Patient got well kit, and those 3 lesions responded for various biological good reason. However, the 2 lesions on the left side of the patient continued to grow, which did not have a RAS mutation. They still had a RAF mutation. So the investigator added, Dr. Rab, added vemurafenib to Velcade. And then in the end, most recently, with combination of Velcade and vemurafenib, patient is responding to all 5 lesions. So we can now target multiple areas using this kind of thing. My friend and colleagues from Arkansas have studied tremelimumab, which is a MEK inhibitor, and has shown excellent response. This study was done before the sequencing were available. If you go after the RAS mutation alone, this is what you may see. And so there's an ongoing study at our institution and others where we are going to treat patient with BRAF mutation with dabrafenib, patient with KRAS mutation on the left side with tremelimumab, and then if they have both the mutation, we are going to use the combination and see how they do to define can we and how well we can treat this patient with his individual drug. So the principle of management of this kind of myeloma, various other combination of myeloma, there is more than one myeloma that exists, we know. Broad-acting agents are still important. We need the dirty drugs because they can target multiple targets, but a specific target agent can be added to eliminate a specific clone there. And we need to evaluate the family of the changes frequently in this patient population. A good example of how the complexity is, this was a whole genome sequencing with 5,000 mutations in a given patient. Following treatment, patient had 12,000 mutations. Very complex cytogenetics. Maybe there are 12,000 myelomas here in one given patient. The important point to remember in my mind is that in this particular patient, this one circle dot is the RAS mutation. Can we expect one drug going after that one dot to treat these 12,000 changes that is present in myeloma? Looks not so likely. And that is the reason why we have rise of immunotherapy, because that can be agnostic to the target, it can target everything. And you will hear a lot of talk about immunotherapy in the later part of this session. So it's a simple answer to a question, how many myelomas are there? I think we knew it for a long time. There are multiple myeloma present. So with that, this is my lab group who has done a lot of work that I showed you, my colleagues and collaborator. Thank you very much.